I'm Rob Horowitz with the Council to Prevent Opioid Dependence, and we're here in our series for another one of our series of webinars on non-opioid pain alternatives to opioid painkillers, which, as people know, have downsides, including the risks of dependence and addiction. We're here with Dr. Jeffrey Kozlik, who is the rehab director at Orthopedic Associates in Cranston and a longtime physical therapist practitioner who works with private clients, private patients, and also works with a number of schools in the area. And we're going to talk about the role of physical therapy in pain relief, how it works generally, and how you could, if you feel the need for a physical therapist, how you can access one, how you can pay for it, sort of the whole gamut, and also some of the evidence, which I know Jeffrey is very familiar with, for why physical therapy can be very effective in treating pain. So, Doctor, I'm going to just start with the basics. What is physical therapy? And maybe, because I think sometimes people get a little confused. How does it differ from massage, for example?
Yeah, that's a great question. What is physical therapy? I think it's still a grossly misunderstood profession, but physical therapy at its core is a movement science. Physical therapists are highly trained, educated individuals. We go to college now for 6 years, culminating in a doctorate degree. Along the way, there's extensive education curriculum in human anatomy and physiology and pharmacology and chemistry and all the basic sciences out there. And along those lines is also extensive clinical training, specifically in manual therapy techniques, in exercise science and exercise prescription, and in pain management. And so physical therapy is a profession that employs a number of different modalities to solve a person's problem. And in most cases, the primary reason why someone seeks out physical therapy is for pain.
What are some of the main modalities?
So physical therapy, depending on the setting you're working in, I'm in an outpatient orthopedic setting. More often than not, the modalities that we use are exercise, manual therapy techniques. There are also passive modalities like ultrasound, electrical stimulation. There's traction devices, application of different heat, cold, thermal modalities, all used together based on a comprehensive assessment and evaluation to treat a person's injured area.
I know, because I know some friends of mine who have had physical therapy where they were recovering from injuries. You also, I believe, you prescribe or teach people how to do exercises that help to promote healing. Could you talk about that?
Yeah. So probably the largest components of our practice is exercise based. The human body has an inherent, innate capacity to heal itself. Sometimes it just needs a little bit of push. More often than not, when I see clients come in with chronic conditions of the shoulder or the knee, whether it's due to a longstanding injury or strain or whatnot, more often than not, there's joint restriction and there's loss of range of motion in a joint, and there's loss of strength or stability in a joint. And that combination oftentimes affects joint health and joint function. If a joint like your knee or your shoulder is stiff and doesn't move as well, or if it's not strong, the joint itself suffers. And the product of that is pain. And so by simply employing strategies to improve flexibility, to improve movement, to improve strength of a joint, the end result of that is pain relief. And so exercise selection, exercise prescription, exercise utilization is probably the largest thing we do. But it's not as simple as, oh, your shoulder hurts, here, do these 3 things, you'll feel better in 2 weeks. There's a lot more science to it than that. And that's why with physical therapy, we do this comprehensive evaluation. We take measurements, we employ tests, we look at all this data and determine, what's the root cause resulting in your pain, and then we can decide what are the best strategies from an exercise-based perspective to give to a patient to help improve their symptoms.
Great. So I was just reading a study actually that was done in Australia that just came out about the difference between opioids and placebos for just giving sugar pills for lower back pain and I think for neck pain, and the difference was pretty much non-existent. What is the at least in this study, I think 200, 300 people published in the Lancet, I believe, for physical therapy. I know there's been a number of studies. Is there evidence of physical therapy's effectiveness in the treatment of pain and also in promoting healing?
Yeah. There's a significant amount of peer-reviewed research that supports the efficacy of physical therapy for back pain, both acute and chronic. And I think, I had written on this several years back. At the time, there was over 60 studies, and that was maybe 5 years ago, that were supporting the efficacy of physical therapy over medication as a first line of treatment for back pain. We know organically, first episode back pain is probably going to fully relieve itself with or without intervention in upwards to 4, 6, 8 weeks. Employing a secondary strategy like physical therapy can accelerate that healing process. The problem comes in is that for years, the healthcare industry has employed a strategy of masking pain while it gets better than getting to the root cause of pain, right? So maybe 20, 30 years ago, whatnot, you hurt your back bad, you couldn't get out of bed. Well, you went to the urgent care center or to your doctor, and they gave you, 30 days of prescription medication, some muscle relaxers, took you out of work, go lie down in bed. We now know that that's probably the worst thing you can do, right? There's been more and more peer-reviewed research coming out supporting movement as a first line of defense or treatment for these type of situations. And so, again, that's where physical therapy's role comes into play. As highly skilled practitioners in movement science, we can look at that person in that situation and get them going in the right direction with the least amount of medication needed.
That's great. So do you work with teams of professionals? You work on in other words, is a doctor and consultant involved? You are a doctor, but is I guess an MD
Sure.
consultant involved?
Yeah.
What team is it? I guess it depends on the case, but how generally speaking do you work with patients?
Yeah, it really, a lot of that depends on the healthcare setting you're in. So physical therapy therapists are employed across a number of different healthcare settings, whether you're in an outpatient arena like I am, or in a hospital, if you're in a home care agency or a skilled nursing facility. Probably in all those different settings, there is some form of team, whether it's therapist, nurse, doctor, or therapist, doctor, or nurse practitioner, physician assistant, doctor, nurse assistant, case manager, whatever. Yes, there's oftentimes teams. One of the benefits of physical therapy within that team is probably the therapist spends the most amount of time, has the most contact points with the patient over their recovery duration. And so the therapist is uniquely positioned where they can easily reach out to the case manager, to the physician, referring provider, to a caregiver, to any other person in that care team and say, hey, this is what's going on. This is what I think we might want to work towards because we spend so much time with the patient.
How do you develop rapport with patients so that because I know, I'll give a terrible example. My mom was older and needed a regimen of physical therapy.
Yeah.
And she was she's no longer with us, a lovely, wonderful woman, but was pretty good at sort of physical therapist torture.
Sure.
Not being tortured, but torturing the physical therapist.
Yeah, sure.
How do you deal with patients who are a little reluctant or a little resistant?
Yeah, probably one of the hardest things to do as a new practitioner, but as you gain experience in the field, you see all kinds of people. You come across all different types of personalities, and I think physical therapists are a different breed in that they go to school, they choose the profession because they truly want to work with and help people. Physical therapists aren't solely focused on brand development. They're not solely focused on compensation of growing an empire. Physical therapists want to come in, they want to work with patients, they want to provide the best care possible. And so with that mindset, organically you find ways to make a connection. More often than not, people who are in pain, they come in and they can be difficult to manage at first. But once you just listen to them and let them talk, which doesn't happen a lot, unfortunately, in a lot of other situations, you'd start to develop a rapport actually more easily than you think, because it doesn't take long for them to figure out that, hey, this person is here not to hurt me, they're here to help me. And so, it can be challenging at times, but more often than not, within the first couple of visits, a rapport is very easily established. And what's great about our profession is it's an individualized approach. We look at you, the person, not you, the number, not you, the diagnosis, but what's your problem? What are your barriers? What are your needs? And let's work with you. So we are teammates. And I think that goes a long way in establishing rapport.
How long is an average physical therapy session, or does it just vary depending on the?
Yeah, again, circling back to the individualized approach, it varies, but typically, at least in the outpatient setting, patients are here depending on a number of other factors, time constraints, transportation constraints, working around work or lunch schedules, but 30 to 60 minutes is probably industry standard. Some a lot some less.
Do you have do people also get or have to have, I guess again it varies, I'm sure individually, post physical therapy exercise regimens that they're responsible to you can't force it, but that if you have, let's say you have a, I don't know, Achilles tendon problem, or you have a sprained ankle or repeated sprained ankles, or whatever it is, better than me what it would be. Is that part of what physical therapists do? Set people up post whatever the therapeutic regimen is?
Right, absolutely. So I think that there's that's probably the most consistent, the biggest thing that we do is try to promote some accountability on the patient side, because maybe there's this perception that the physical therapist has this magical hands, and you come in with a sprained ankle or a sprained knee, and you can do these 1 or 2, 3 different maneuvers, and then you put this thing on the knee, and okay, you're pretty good, you're all set. Unfortunately, it's not that easy. Physical therapy is more about working with the patient to get them on a set program. Now, you're coming to me 1, 2, maybe 3 times a week, but there's still 4 other days in the week. And so there's every day there needs to be consistency with managing a problem. So, the unwritten rule in physical therapy is everyone should have a home exercise strategy, regimen, program. Doesn't always have to be just exercise based, but yes, the patient has just as much responsibility and accountability in their recovery as the physical therapist. So absolutely, home exercises should be part of nearly every program. Yeah.
And innovations in the last, say, 10, in other words, are there things you now do in physical therapy you might not have done 10 or 15 years ago? Are there new methodologies?
Yeah. I'd say probably the most prominent is dry needling, which more and more therapists are getting certifications in. And dry needling essentially is it's a style, it's a form of acupuncture with a different theoretical model. There's been some good research coming out that's proving its efficacy, not as a standalone treatment, but in addition to the manual therapy techniques that we employ and the exercises that we prescribe. Dry needling is probably in the forefront of a new tool in our toolkit. Kinesiology taping is another area that receives a lot more attention and popularity. That's been around for a long time, since the 70s, but here in the United States didn't really gain a lot of traction until the Summer Olympics in early mid-2000s, I think it was. And those are probably two of the bigger, newer things that we see.
What is kinesiology taping?
Kinesiology taping is a special tape. It's a cotton-based stretchable tape. So you think of like Scotch tape or duct tape. You can't maneuver that. Kinesiology tape is a tape that you can apply to a joint or to a muscle. That if you put it on with a specific technique, specifically on a stretch, when that joint comes back to its resting length, it recoils, creates this lift or this compressive support. And it's similar to maybe bracing or using, going to the store and buying a compression sleeve or something like that, something that provides some support and comfort to a joint. But the benefit of the kinesiology tape is it doesn't really inhibit the motion. It's no restriction with that. So you can use it and it won't, hold back your joint motion. Additionally, taping, if applied correctly, can stay on for 1, 2, 3, 5 days in many cases, 24/7. So that joint gets a lot of extra support versus, the couple hour use you do when you put a sleeve or a brace on.
Thank you. So I do know that you work with schools, I assume with athletic departments and with school folks. We find, and we work a fair amount on the sort of opioid prevention side with schools as well, because we find a real source of dependence and addiction are people, especially, as you were saying several years ago, but still going on, is sports injuries where teenagers who are started on an opioid pain reliever regimen.
Yeah.
And for some people, not most, but for some people, dependence can happen in as little as 5 days. People are predisposed. So I was wondering, how do you work with people in the school setting? How, what are the kinds of issues you confront, and working with teenagers? And I'm just assuming you're working with teenagers, but working with kids of all ages.
Yeah, we do see quite a few in the clinic here. We do see quite a few high school athletes that come in more often than not, mostly during football and soccer season. Those seem to be the big sports where they're sustaining these type of injuries. And unfortunately, I'm seeing more and more younger kids with back problems. And I think a lot of that has to do with, the postures and the more sedentary lifestyles that kids are living nowadays. Again, one of the benefits of being a physical therapist, working with a kid, is they're coming here 2-3 times a week with an injury. And again, they're with us for an hour each time, and they're here for 4 to 6 weeks. So doing the math, they're here with us, for a while, up to 16, whatever, 20 hours or whatnot. And during that time, there's a lot of conversation, because it's not just you sit here for an hour in dead silence, you're constantly conversing, you're constantly talking. And when you're able to develop a good, strong rapport, comfort, and confidence with the patient, they relay a lot more information. And, during our intake, our initial evaluation, we'll have a good understanding of what they're using for medications. And certainly any young kid who's on an opiate, that would set a red flag for us, because we would expect young kids should respond a lot faster from a pain perspective than, say, a 40, 50, 60-year-old person. And so, if we're starting to see some signs of misuse, if we're seeing improvements in motion, improvements in strength, improvements in function, but we're not seeing any change in opioid usage in terms of, I'm using my Percocet, twice a day, 3 times a day, but wait, your motion's nearly full now, you're not walking with a limp. There's a gross mismatch
Right.
there. So we would be on the phone with the referring provider or prescribing provider pretty quickly with that. Fortunately, I'd say in the last, since before the pandemic, haven't really seen many issues with that, at least in the clinics that I've been in.
Yeah, we've also noted an improvement.
Yeah.
Numbers, of course. The problem is with the advent of fentanyl, the costs of dependence have gone. It's as people graduate, unfortunately, to
Right.
heroin or fentanyl, and even if they don't, just because it's laced, that's one of the reasons we're seeing such an increase in overdoses. After we were starting to see at least some reduction.
Right.
Some of that was the pandemic, but some of it's also just the widespread distribution of fentanyl.
Yeah.
So all the more important for people to not to editorialize in the middle of the webinar, but all more important for people to look at alternatives like physical therapy, and
Yeah,
for the kids
absolutely.
and also for themselves, so they don't get started down what could be a bad road.
Absolutely. And it's been encouraging for me, because when I first started in outpatient orthopedics back in 2005, every shoulder surgery, every knee surgery, every major injury, you had an automatic prescription of Vicodin for 30 days that you could use 3 to 4 times a day, and that would be allowed to be refilled up to 3 times before anyone started questioning that. And now you fast forward, whatever, nearly 20 years later, and the surgical techniques and surgical innovation has evolved so much that patients are coming out of these procedures with much less pain. Of course, prescribing strategies are a lot different now than they were back then. And
Right.
while there's been a huge issue with burnout in healthcare since the pandemic, a lot of the new providers coming in, these newer practitioners, nurse practitioners, medical doctors, orthopedists, physicians assistants, they're coming out of school a year, 2 or 3 years ago now with a complete different mindset on the utilization of opioids. And a lot of these practitioners now are very pro-therapy. So what used to be med management, bed rest, come back and see me in 4 to 6 weeks. If you're not better, start physical therapy. Now it's the opposite. You hurt yourself 2 days ago, you go to get in to see an orthopedist or a physician assistant. The first line of approach many times now is physical therapy, which has been great.
No, that's great, because where you see sort of new cases of dependence is around acute pain, because that's where, because people who have chronic pain, if they're not that it's good, but if they've been on an opiate for a long time, that is what, I shouldn't say that is what it is, because there's still ways to get off what it is, but it's where you get new addicts, new people who struggle with substance abuse. Sort of, it's on the acute pain side, because if they get prescribed and they just happen to have those predispositions, which no one knows about because it's brain chemistry and
Yeah,
until it happens. It's not that we don't know about it generally, but not in every individual case. So
right.
that is really good to hear.
Yeah.
A couple other questions. If someone thinks they need physical therapy, how do they get in touch with somebody like you? How does it get paid for? Do they need a referral from a physician? Just generally speaking,
Yeah.
how's the sort of navigating the healthcare system process
Sure,
work?
sure. So generally speaking, in Rhode Island, fortunately, Rhode Island does allow direct access to physical therapy. So a patient can go directly to a physical therapist from the street and seek treatment. That gets a little gray because some of the insurers won't recognize that or cover that. The safest route is to get a referral or a prescription from a medical provider, typically the primary care provider or an orthopedist or a neurologist or whatnot. From there, it's very simple. You have choice and access. So you can Google any physical therapy practice. You can call and schedule an appointment with a physical therapist. Physical therapy, more often than not, is covered by your health insurance. The difference being some insurances will only cover maybe 6, 9, 12 visits per calendar year. Some may have unlimited, some may be 30, 60 visits per calendar year. Most physical therapy clinics will verify the insurance and what your benefit is and make you aware of that so you can make informed decisions, informed choices. But it's just as simple as getting a script and finding a therapist and setting up an appointment. And then on the reimbursement side, therapists will submit charges, submit claims to the insurer. The insurer will pay, and the patient's responsible for their portion of co-insurance or co-payment based on their health benefit.
That's very, very helpful.
Yeah.
Do you think, and because out of our sister organization, excuse me, use the correct, let me pronounce the word correctly, prevent opioid abuse, we do some advocacy work. Do you think there's a need for expanded insurance coverage of physical therapy? I know I'm asking a physical therapist that, but would that be helpful? Or are there some patients who just can't afford just
Yeah.
because of how their insurance is structured?
Yeah, I'm really glad you asked that question because that's a huge problem. And the Rhode Island chapter of the American Physical Therapy Association is working on legislation, as far as I know right now, specifically to address that. One of the biggest problems I encounter on a daily basis is cost and access. And if you think about the 3 pillars of healthcare, there's access to healthcare, there's the cost of healthcare, and there's the quality of healthcare. The quality of healthcare, I think, is there, and probably a biased opinion, but I think physical therapists are excellent practitioners to treat musculoskeletal conditions, among other things. The problem we have, not only here in Rhode Island, but I think across the nation, is still an issue with cost and access. On a daily basis, patients discuss with me tailoring their treatments because they can't afford $60 co-payments twice, 3 times a week. They can't afford the high deductible payments that they need to make to come to therapy. I'm confident that down the road there will be some legislation, some solution to allow for more uninhibited access to physical therapy, because the statistics don't lie. And again, maybe partially a biased opinion being a physical therapist, but I've seen firsthand far too many times the benefits of it. The peer-reviewed research supports the efficacy of it. At some point, someone needs to look at this and say, okay, we could probably save a lot more money if we just allow these patients a little bit more unimpeded access to therapy, let them do their thing. And I think more cases than not, patients would be successful. Absolutely.
Yeah, and to build on that point, even in terms of dependence and addiction, if more people are diverted to
Yeah,
non-opioid alternatives, you get one. Most importantly, you prevent ruined lives, and treatment, no matter how good it is still hit or miss.
right,
And treatment's very expensive. So even just from a pure dollar and cents standpoint,
right.
for example, labor unions that self-insure, like where people get a lot of injuries, building trades, they're very interested in non-opioid alternatives, partially because they care about their members, but partially because it's very, once people are in treatment, you're talking hundreds of thousands of dollars,
Yeah,
as opposed to physical therapy, several $1,000s, whatever it is. So I agree with you, even from just a pure state of Rhode Island national dollars and cents standpoint, to not more broadly ensure these non-opioid alternatives, physical therapy, there's several others, as you know, is very maybe penny wise, but it's certainly pound foolish to draw on
yeah,
an old cliche.
yeah.
This has been great. Couple other, do you have any things that we've missed you'd like to add?
Oh,
Dr.
wow.
We had a
Um,
pretty far-ranging conversation, but is there like a couple points that we didn't cover you would like to raise? If there's not, it's fine too.
yeah, well, no, I think we covered a lot, and I really enjoyed the question and answer style, because it really allowed us to kind of cover a lot of different areas. Again, physical therapy is a bit misunderstood, and for clarification, one of the other challenges I find with new patients is that there's this perception perhaps out there that physical therapy is a painful process. And for those who have concerns about accessing physical therapy, and maybe not trying physical therapy because they feel it's going to be a painful process, I want to reinforce that that's not the situation at all. In fact, it's quite the opposite. Putting someone who's in pain into further pain does not really pay any dividend for the therapist or for the patient. A good physical therapist is going to meet with someone who has a problem, who has pain. They're going to sit down, they're going to understand that person's unique situation. They're going to ask the questions that they need to understand and get a good comprehensive view of what the patient's goals are, what the patient needs to get back to their baseline level of function. And then we're going to work alongside the patient as a teammate to get them to a level where they can either A, carry it over on their own, or B, they get back to their pre-injury kind of baseline level of function and can get back into gainful employment, back to their job, back to living a better quality of life. And so that's probably one of the things that I think we should stress, is that physical therapy shouldn't be a painful process. In fact, it should be the opposite. It should be something that helps you get out of pain into a more quality standard of living.
Well, that sounds like a great place to end this conversation. I'd like to thank Dr. Kozlik. This has been very, very useful. For anyone watching right now, all our other webinars are available on our website in this series, and this one will be available. Plus, if you want to review the high points, will be up for people to view on the website, and we'll have an announcement on when our next webinar is. Dr. Kozlik, thank you. Really appreciate your time. This was very informative.
Sure.
And highlighted a really key pain relief alternative to avoiding getting dependent on opioid pain relievers. Thanks again. Thank you
Great.
very much.
Thank you very much. Appreciate it. Have a great day.